Hello, classmates. Um, Commenting on our chapter, the two things that I feel like stood out were that sometimes we have a responsibility to talk to our clients about meds, and we obviously don't want to step outside of our scope of practice because we don't prescribe psychiatric meds, but there's still relevance that our clients would be talking to us possibly about their symptoms or curiosity about how to access psychiatric assessment, so it's still relevant. And then the other one is caseload size, mostly just because I've worked in different types of settings as far as intensity goes, and my caseload did fluctuate based on those different intensities. So I guess I just wanted to speak to my familiarity with some of this stuff, but then also things that have left me kind of uncertain. Um, I guess first things first, in the chapter of the book, it talks about how Newkirk had 140 clients and that seeing all of them was pretty much impossible. So I recall in outpatient, I would have about 23 to 25 clients. I would meet with them. I would sometimes call their parents if they requested a check-in. Other than that, it was pretty direct. Whereas in an intensive caseload, I had about 10 to 15 clients, but I spent a lot of time coordinating with DHS, coordinating with screeners for higher care, coordinating with counselors to make sure that they were fit with an appropriate counselor for their needs, IEP and 504 meetings, uh, a lot of psychiatric referrals and psychological referrals, which are oddly harder to find. Um, all sorts of collaborative care, and I believe that it did help clients receive better care because I was putting myself out there, getting to know different types of agencies. And if I hadn't done that work, then maybe they would have ended up in a setting that wasn't appropriate for them. Um, Speaking to the second part on the psych meds, I obviously know that we cannot prescribe. That is within our code of ethics, where we're staying in our boundaries of competence, C.2.A. And so when clients bring up meds in assessment, I usually just ask how their symptoms are going, if it's helping. And if I ask them if they take meds and they answer with a no, then I just ask if that's something they'd be interested in. I remind them that I'm not able to prescribe or really give a deep explanation of what would be appropriate for them. But based on diagnosis or symptoms, I can at least find them a psych provider that would be more appropriate. Um, I've become a little bit familiar with some of the ones in the area. Some are better for ADHD, some are better for all sorts of different diagnoses. So, um, what am I still unsure about? Probably the coordinating care with minors. Definitely had a situation where a 17-year-old disclosed that he was taking his anxiety meds higher dosage than he was prescribed. And because he was 17, it was very difficult communicating with the parent on an ethical level. And he also didn't give me a release of information for his meds prescriber. So technically, code, what is it? B.5.B talks about parental consent and guardians as far as their involvement. I did end up alerting this client's parent to be looking out for any behavioral changes that might be concerning, and they asked why. I honestly just told them that there might be a change in behavior, and I want to make sure that the client is appropriately monitored in case they need help. Um, I still didn't feel settled about it. I don't know if I do now. Client's okay, things have moved on, but I wasn't sure how far to take that one and when it might be appropriate to just simply contact a provider if I have that type of concern. So I do think case management supports independence, but it does have to be organized and at least within the client's understanding of what their options are. Um, in my experience, doing home visits, going to kids' schools, seeing how they're doing, advocating them for courts and IEP meetings really seem to empower them to be their real selves and show me and others what they needed. Whereas if they were just scanned and screened as a piece of paper with a presentation of symptoms, they might not have gotten into the right types of settings. So I think collaborative care works, but it works best when you know the client well and they know their resources. So go team.